heard a lot of talk about collaboration amongst our medical and dental providers. I think that's super important, and I think part of what I'll show you today is hopefully we'll kind of bridge that gap for many of you who haven't seen some of this. But I'm an orthodontist, and I've been straightening teeth since 1992, going way back. So we do see a lot of young children, and we do feel it's very important. We like to meet the children when they're around age 7, which is a great time for us to do our first evaluation. And part of that is because of what we're talking about here today. So let me kind of go through some stuff you've already seen, but obstructive sleep apnea, we all know it's a disorder that's characterized by pauses in breathing. Each occurrence can last just for a little while or even longer. Usually goes undiagnosed, but there's some physical obstruction of the airway. So we've seen a lot about this. As we read a lot of the literature that focuses on what I do, this fellow's name keeps coming up over and over. But he was the one who initially described pediatric OSA back in 1976. He's a medical doctor out of Stanford. He's still doing his thing out there. He's got hundreds of articles on the subject out there in the literature. But he summarizes pediatric OSA in non-obese children is a disorder of oral facial growth. Oral facial growth is what I do. That's what orthodontists do that have training in young, growing faces. That's what we do. So dysfunction leads to dysmorphism. This is in the Advances in Otolaryngology in 2017. So there's a lot of different ways of saying that. Form follows function, right? The things we learned early. So if there's some dysfunction, if something's not working properly, they're going to look different. They're going to be dysmorphic. Form follows function. So I want y'all to meet Jody. Jody's an adult patient of mine with severe sleep apnea. She developed sleep apnea as an adult, and so we're talking about pediatric sleep apnea, so sorry about that. But this was a really dramatic case, and I wanted those of you who are not in the dental profession to see her teeth, to understand this form follows function thing. So she put on a lot of weight. I've known Jody for many years, and she put on a lot of weight later in life, and that's when she developed the sleep apnea. So she wears CPAP, and there's nothing I can do dentally with appliances or anything else that will help her. So she's on CPAP. But take a look at her teeth. So the teeth move in response to pressures that are being applied to them. So her teeth didn't look like this before, but her tongue comes forward in her mouth. She's got all the excess weight. She's breathing, through her mouth, so it affects the gums. But this is what happens to the teeth. They move in response to various things that are happening to them. The orthodontists in the room know this already, and I know the dentists also do. But this is why it's important to take a look at the teeth. See, there's signs and symptoms that are readily available to all of us who are used to looking into the mouth. Those teeth really get to moving. So this is what she used to look like. That's what her teeth used to look like before all the movement that occurred. So those teeth used to touch. There were no spaces in between. They weren't flared out tremendously. And so this is some of the pretty dramatic changes. It's a little hard to imagine these changes in children. I've got some pictures I'll show you later, but that was a really nice dramatic image I thought would be helpful to get things started. So dysfunction leads to dysmorphism. And later in the article, the same article, he says that pediatricians and pediatric subspecialists are often unaware of the advances and the remedies that are available. And I think he was kind of alluding to orthodontic remedies. From the National Sleep Foundation, which is mostly a direct-to-the-public group, a lot of their information is for public consumption. What causes sleep apnea? Small airway. It's affected by a large tongue, tonsils, uvula, being overweight is a big one. It also has having a recessed chin, small jaw, or large overbite. Now that sounds like something that might be on an orthodontist website. If you have a recessed chin, a small jaw, or large overbite, you might be a candidate for orthodontic treatment. You also might have sleep apnea. OSA may run in some families, suggesting a genetic or certainly environmental component. So if you're treating an adult with sleep apnea, it's likely that their children will also be likely to develop it maybe later in life. So refer those patients for an evaluation, the children. The American Dental Association rarely administers guidelines to our entire dental profession, which is, I think, close to 150,000 dentists in the United States. They don't like administering these guidelines because it puts a substantial medical legal burden on the dentist, right? So if they say, well, these are the guidelines, and Mr. Dentist, Mrs. Dentist, you're not doing this. Well, guess what? When we're testifying in front of the jury, we're going to be in trouble. So they don't really like putting these guidelines out, but they've done this on sleep apnea very recently. And one of the first things they put in there, which I was pretty excited about, especially after hearing some of the medical doctors today, we should work in conjunction with our colleagues in medicine. Referral, right? Dentists have various methods of mitigating these disorders, but we need to work together with our medical friends. And in children, the dentist recognition of suboptimal craniofacial growth and development, so again, that's right in the orthodontist wheelhouse, oral facial growth, and other risk factors can lead to a medical referral or an orthodontic orthopedic intervention to treat or prevent sleep-related breathing disorders. So this recommendation was sent out to every dentist in the United States. So they want us to screen every patient. Every patient that comes through a dentist's door for evaluation, children or adult, the American Dental Association is now recommending that we screen them all for obstructive sleep apnea. Orthodontics is health care. This is kind of shocking to some. I think over the years, orthodontics has kind of been put into the cosmetic world. It's right there with tummy tucks and chin lifts and all this sort of thing. There you go. Don't forget hair. But orthodontics is health care. So, and tooth alignment, straight teeth, crooked teeth, is dependent on the proper development of our jaws. So I'm going to go down a rabbit hole with you guys a little bit here and kind of dig into that a little deeper. But there's a genetic and environmental factors that really make a big difference on the development of our jaws. And certainly tonsils and adenoids and all those things that we've heard about already have a major component to that. But early intervention by an orthodontic specialist who has training and experience in this dentofacial orthopedics, we can modify jaw development to a pretty substantial degree if we meet the patient when they're young. So dentofacial orthopedics, a lot of people don't know, is actually the second half of our specialty. We're called orthodontists and dentofacial orthopedists. That's the actual name of our specialty. But people just know us as the orthodontist, right? We move teeth, we put braces on. We also do this dentofacial orthopedics to a large degree. At least probably a third of our practice, I think, is rolled up in this, in my practice. So the maxilla and mandible, upper and lower jaw, are defined as irregular bones. The maxilla has sutures, and they grow in a similar fashion to our cranial bones that house our brain. The maxilla, the upper jaw, articulates with 9 other bones. So the maxilla is right in the middle of all the action. Its boundaries with 3 cavities, the roof of the mouth, the floor and the lateral walls of the nasal cavity, as well as the orbit. The maxilla is right there. So here's a nice picture I downloaded from the internet. You can see the maxilla and all this cool stuff. And I like to point out these little white things down here at the bottom for our medical colleagues. Those are the teeth, right? The teeth are important. So we're going to drill down a little bit more for the teeth.
Dentists like to drill.
We do. We love drilling. We do. So this next picture, just a different view, but it shows the sutures are the connections between the bones, and then the teeth are the connections between the upper and the lower jaw. So they're all important. They all serve a function. And when something's out of order, you're going to see it. It's going to create dysmorphism. Here's a peeled away view of the upper jaw. And as an orthodontist, we can affect virtually every one of those sutures that you see laid out there. But our favorite one is the one that goes right down the middle. It's the mid-palatal suture, because I can apply an orthopedic device. I can put on the teeth, and I can have an effect on those sutures. We can make the palate bigger. So when Dr. McClay was talking about his patients that the tonsillectomy, atomectomy didn't quite work, there's this list of other things that you might try. Expanding the palate might be on that list. So there's a big important difference between orthodontic forces, which are forces that move a tooth. We do that with our braces. We do that with a lot of things, but it takes light, continuous pressure to move a tooth. So like you saw with Jody, that crazy patient, she had light, continuous pressures being applied to her teeth by her tongue, and it slowly moved her teeth. But it had no effect on her jaw structure, it just moved her teeth. To move the bones, to affect the bones, we have to have heavy, intermittent forces, exactly opposite. So if there's an orthodontist trying to affect the palate by expanding the mid-palatal suture with braces, it's just not going to work. It just doesn't work. You have to have orthopedic forces, which is a little device called an expander, rapid maxillary expander, that we attach to these young kids, and they work fantastically. So the mandible, the lower jaw, connects to the maxilla, and the teeth themselves are the connectors. So just like a joint or these sutures, we're connecting one bone to the other, and that's what the teeth do. The lower jaw is more like a long bone. It's shaped like a U. The growth plates are on either end. Totally different bone, right? It grows differently. We can't affect the lower jaw with the stuff that we do. And like a sling, the lower jaw can move in any direction. Our TMJ, the joint that keeps those things together, is the most complicated joint in the body because of all the different directions that it can move. And there's one on each side, so they have to work in concert with each other. And the teeth, unfortunately, are the weak link in all of this, and they're the most affected by problems with all these things. So the teeth are going to move, and they're going to become dysmorphic based on what's happening. So the lower jaw's got anterior, posterior, vertical, lateral position. It's all determined by the developing maxilla, because the lower jaw has to fit the upper jaw, and the position of the teeth. So where the teeth are affects the upper and the lower jaw. It's all goes together. There's the lower, and there's our same picture showing those crazy teeth and how they have to fit together. So the teeth's role. Our teeth are very adaptable. They're going to move to adjust to the jaw position. And I want y'all to just remember Jody's picture. And there's an ideal position of the teeth relative to the jaws and to each other that orthodontists have been perfecting for over 120 years. The specialty of orthodontics has been around since the turn of the 20th century, around 1900. And the United States was the first place really that this came about. We're the first ever dental specialty. Might be one of the first ever specialties of any kind in medicine or dentistry. But crooked teeth are a symptom of poor development and function. Why is that? So the crooked teeth are a symptom. It's because form follows function. Straight teeth look good. That's, I think, why we're in the cosmetic world, maybe in some people's minds. We have to remember that this form follows function. So if your teeth look good, they're probably functioning properly also. But straight teeth also maintain a healthy jaw position. So if your teeth are in the right place three-dimensionally, your lower jaw can fit properly with your upper jaw, which we all know is very important in sleep apnea. And the occlusion or the bite, the teeth have to fit together. Our muscles of mastication, our chewing muscles, combined with a good solid occlusion, are going to create stability for us while we're chewing, while we're speaking, and while we're sleeping. Straight teeth that fit well together are easier to care for, to keep clean, and they last longer. So those are indisputable facts. So I would suggest to anybody who looks in the mouth, if you see something with the teeth, say something to the patient. Like if you look in Jody's mouth or a little kid, you have some basic understanding of what's going on with those teeth. And just like we do when we look in their mouth and we look at their tonsils. We take a look back there and we see if they have enlarged tonsils. Now, those are all clues to us because the inability for a patient to breathe properly will affect their teeth. There's no question about that. So here's a little guy. Wow, those are pretty nice teeth. The orthodontist in the room recognized quickly that there's a missing tooth. There's a tooth that's not there. And so that's a clue. But orthodontic treatment for a medical problem. This is fantastic stuff. So we already talked about dentofacial orthopedics. That's the second part of our specialty. Our favorite tool, we have many, but our favorite one is this palate expander, the rapid maxillary expander, RME. We also use these little things called Schwartz appliances. You know, we, like everybody else, we name stuff after people. Lip bumpers, functional appliances, these bionator, herps, activators, forces. All these things are called class 2 correctors. Most of these things were put out to our specialty back probably in the 40s and 50s, and a lot of it came out of Eastern Europe. Over there, they didn't really have the capability of braces and all that stuff, so they developed all these correction devices that were removable, and they'd put them in the patient. They had these patients with these big overbites and stuff, and they'd fix their overbites and they'd improve their teeth. Well, later, you know, those same appliances evolved into snoring appliances, but it all came from orthodontic treatment of large overbites. So we know that these things can advance mandibles, change the way the jaws fit together. So these snoring appliances, you know, their genesis, you know, goes back to orthodontic appliances that have been proven very, very effective for decades. We also use face masks. These are external devices that the patient may need to wear if they have an underbite. Again, we're affecting the sutures in a growing patient, where we can grab a hold of the maxilla and with little rubber bands, affect the sutures and bring the entire maxilla forward in three-dimensional space, which we all know helps the airway. So some typical orofacial features of these sleep-disturbed breathing patients. I put this long face or adenoid facies up there. You know, that's a classic study that I think was one of the first studies they showed us in orthodontics. It's fun to talk about. They took a group of monkeys, rhesus monkeys, and they had genetically identical, you know, background, and they were raised in the environment. And half the monkeys at birth, or very close to that, they took a little silicone plug and they jammed it up both their nostrils. So these little guys, these little monkeys, couldn't breathe through their nose while they were growing. And so they developed what became known in this classic article as an adenoid facies. And all that means is, since they couldn't breathe through their nose, they had to do some alternative things. They had to breathe mostly through their mouth. And so these little monkeys would walk around with their mouth open all the time, breathe through their mouth. They developed these extremely narrow palates, so the upper jaw started to go up really high like that. And the mandible was affected, the lower jaw, teeth became crowded. They got what in orthodontic terms we call class 2, just means that's an overbite. So monkeys aren't supposed to get overbites. They forced these silicone plugs up their nose, and they changed the way they breathe, and they created massive orthodontic problems. So when we recognize that these kids are breathing not through their nose but through their mouth, and they function differently, we know that that's going to have an effect on how things look, and we can help that. So here's a younger patient, a typical patient. So you know, we take a lot of pictures of our patients. It helps us communicate with the parent. This guy's, the first thing that stands out, he's got a big overbite, right? His upper teeth stick way out. Also, when he smiles, and this is not a real big giant smile, but you see a lot of his upper jaw, right? You see all of his gums. It's not normal, right? This is dysmorphism. From the side view, you know, his nose, he's got that obtuse angle to his nose, turned up. We ask him to put their lips together for the photograph, and it's hard for him to do that. There's a lot of strain in his muscles just to get his lips together. So he's got that adenoid facies, right? It's a long face. His soft tissue, his lips are not working properly. His teeth stick out. Same thing that happened to those monkeys. So he's got a narrow palate. So you dig a little deeper, you look inside. The two-dimensional photographs, excuse me, do not do justice to this. You know, you can't show that even to the parents. But you actually physically look in the mouth, and this palate, it is way up there. I mean, this is really, really narrow. And that's because he's still young and growing, we can affect him. He's got the missing tooth on the lower. This was his slide from earlier. My headline at the top there is you want to look for symmetry. It's very simple. Just look in there. If the left side of the mouth is different from the right, it's a clue. There's something going on that's causing that. He's got this trapped mandible with crowding. Those lower teeth just don't have room. The bite's way off. You know, this is orthodontic stuff. His teeth just don't fit very well together. But the obvious stuff is up there in the front. Those two front teeth. That's what got Mama to come into my office. My kid's teeth stick out. Yeah, they do. And he's got a few other things too. But orthodontics really meets medicine. So the American Association of Orthodontists, which is the specialty inside of dentistry, we've got about 9,000 orthodontists in this country. We're a little late to the party, but we put together a task force on sleep apnea, just like all the other groups that have already been represented today. And I was one of the members of the task force, and we're in the middle of about a 2-year process. But there are 12 clinicians, medical doctors and dentists, orthodontists, with an interest and experience and expertise in OSA. It's a 2-year project, and what our goal is, we're going to create a position paper, again, just like the American Dental Association. We don't like doing this very often because it's going to place a medical legal burden on our orthodontists, but we felt it was necessary to do that. The very first paragraph, we haven't finalized the paper yet, but it talks about this is a medical condition. We have to work with our medical colleagues. We can't, legally and many other ways, we can't diagnose sleep apnea. And it's critically important that we work in a collaborative manner with our medical colleagues. There's a symposium similar to this one that we're planning for January. So I'll put it up on the slide if anybody wants to see that. But it's a 3-day symposium, and we've got orthodontists, dentists, medical doctors. Kristen G. Minot, the name I put up there earlier, is going to be speaking. We've got neurologists, so it's not just orthodontics. Anyone in this room would get some really good information out of this. And it's in Marco Island. If you don't like the symposium, go to the beach. But the dental profession's role in sleep disturbed breathing is screening, team approach with our medical providers. We've got to get ourselves educated on this. We need to be able to make a referral. It was interesting hearing the questions that came out, and thank you, Dr. Mockbill, for explaining some of that on the referral. But we've got to get them to the right person. It works in reverse, right? So those of you in the medical field, get them to the right, perhaps dental provider, perhaps an orthodontist, if the patient's growing and changing, you see some signs in the teeth. We perform adjunctive therapy. We can't file any of this on medical insurance. It has to all be done as an adjunctive therapy. There is orthodontic insurance that covers some of this stuff. For adults, it's these sleep appliances, again, that came out of the orthodontic armamentarium all those years ago. But for children, it's jaw development. It's orofacial growth and development. We can make a palate bigger, non-surgically, and the kids actually have fun with these things. I mean, it's hard to imagine. But we're performing non-surgical distraction osteogenesis on the upper jaw. The parents reach inside and turn this little key, and these intermittent heavy forces are being applied to the maxillary midline suture, and the palate gets big. When I say big, I mean we can expand it out a ½ inch, right? 10, 14 millimeters without any problem if they're young. If they get into their teenage years, 12, 13, 14, it becomes much more difficult. So here's some imaging. This is classic orthodontic imaging that we've used for many years. This is diagnostic for orthodontists. I can look at that and say, hey, that kid's got a class 2. That's our term for a big overbite. And he's got an underdeveloped lower jaw, and his teeth are in a certain position. But I can't use that to diagnose sleep apnea. Unfortunately, these images are sometimes being used for that, for diagnostic, and they just don't work. Let me back that up. So this image, you can actually see the airway, right? Everybody see that? You got a pretty good look at the airway, at least in profile. But now in our field, in dentistry, in particular in orthodontics, we've got this, what to me is magic. It's cone beam computed tomography. So it's a CT for dentistry, very low dosage, extremely beneficial. They're doing study after study after study on these images now to show before and after for sleep apnea, for palate expansion, for all kinds of stuff. Because I can slice and dice these images however I want. And we can use various software applications, to this case, look at the airway. We can pull out the airway like it's a model by itself. And this is what the software can do. We can measure the airway on a certain, in certain regions, the whole thing if we want. The program, turns it colors if it's problematic. So we're all very visual people. So you got a lot of red, it's bad. But this is somebody's airway. We've got the minimal cross-sectional area, 78.7. The total volume of his airway is 6.4 cc's. Tremendous amount of data is built into these images, and all these studies are really getting into it. This is a totally different patient. His airway looks bigger, looks wider, and it's not as narrow as the other one. It's been strangulated. Everybody see that? So we pulled the airway. It's like somebody grabbed it and just choked it in the middle. So you can't see much just from the side or from the front. You got to look at it in 3 dimensions. So great stuff. So minimal cross-section area, total volume. You can see all that stuff with these images. So as experts in orofacial growth, that's orthodontists. But this article was kind of aimed at a lot of different folks. But it's the critical role of orofacial growth in the evidence. It's sort of a review article. And it was aimed at pediatric dentists, pediatricians, ear, nose, and throat, allergists, orthodontists. These are all people that are on the front line of pediatric care, in our nation. So the conclusion: pediatric OSA in non-obese children is a disorder of orofacial growth. That's that same quote I had earlier. So if you have a patient in front of you that's got OSA and they're not obese, and wow, you scratch your head, their tonsils, adenoids are fine, they're not having problems there, it may be something going on with their growth and development. Orthodontic specialists are uniquely qualified in this arena. We have the training, we have the experience, we have the staff, the protocols to deal with this if we can meet the patient at the appropriate age. So the clinical presentation timeline, I'll go through this quickly. From birth to age 6, that's when these breathing problems first appear. Dr. McClay mentioned that tonsils and adenoids are getting bigger. It's affecting their breathing, just like those monkeys that got the silicone jammed in their nose. These kids are starting to develop differently. You're going to start to see signs with the teeth. They're being because of the growth of the tonsils and adenoids. It's going to alter the growth of their jaws permanently if you don't intervene. These kids many times will have oral habits. They'll suck on a finger, a thumb. They'll chew on a little device, their hair, all sorts of things. But they're changing the way they function, which is going to have an effect on the teeth and the growing jaws. 6 to 10, that's kind of in the orthodontist wheelhouse. That's when we really like to meet our patients. They've got a mixture at this point of adult and baby teeth. And the primary teeth, the baby teeth are starting to fall out. The tooth fairy is very prominent at this time. But their bite is developing. That connector between the upper and lower jaw, their final adult occlusion is developing. And as they get older, they go through this prepubertal growth stage, and their adult teeth are coming in, and then pretty soon they're done growing. And this is really our last chance for any kind of non-surgical orthodontic intervention. And their final bite is coming together. And while we can change bites, with adults, anybody of any age can have orthodontic treatment, we can only do dentofacial orthopedics on young people. So sleep medicine, 2015. This goes into rapid mouthcare expansion for pediatric obstructive sleep apnea, a 12-year follow-up. This is my favorite study out of all those articles that we had to read for the task force. This is my favorite one because it makes orthodontists look really good. But the study design it's a small study, granted, but these are difficult studies to do, right? So they had 31 subjects who were diagnosed with a PSG, with pediatric obstructive sleep apnea. Their tonsils and adenoids were normal, no problem. They did not take them out. They left them in there because they were normal. But they did do prepubertal palatal expansion on all of these patients, all 31. So they had OSA, tonsils and adenoids are normal. They did expanders. They did a 12-year follow-up on these patients. So they brought them back. They lost a few of them. They lost 8 along the way for various reasons. But they got 23 that came back. 100% were clear of obstructive sleep apnea as adults. So they had it as children for whatever reason. Tonsils and adenoids were perfectly normal. Expanders cured, in air quotes, all 23. Now maybe they controlled their weight. I get all that. But this is pretty powerful information. And you add that up with a lot of other studies that were being done over the last couple of decades. And it's important that we just look at the face and the teeth. And that's what this careful analysis of orofacial abnormalities, where I've underlined it in red. Look at the face and the teeth. They say to evaluate the tonsils and the adenoids. Very important. Some kids may respond best to palatal distraction, our rapid maxillary expanders that I'm talking about. So you have to look at all these things, right? Our head and neck is very complicated. Those teeth are symptoms, signs that we can easily look at. They got sustained resolution from their OSA, but we had to do the rapid maxillary expander pre-pubertally, right, when they were still young and growing. So then they say, well, maybe they're just saying one may question if orthodontic treatment should not be the first approach, if clinical evaluation and testing indicate the presence of both problems. In other words, what they're saying there in their discussion is the patient presents with enlarged tonsils and adenoids. We know those are going to shrink as they grow older, and they have a narrow palate. Maybe orthodontics should be considered first. They're not recommending that. They're just saying, think about it. Parents are, oh, I don't want to do surgery. Okay, there's a non-surgical approach that shows pretty good results. Go talk to your orthodontist. You may not need a tonsillectomy, adenectomy. And the great thing is there's good research that shows you can get stable, long-term results from this. So in dentistry, we've got to screen these patients. So I came across some things, and I know we've got a lot of different screening things. We do this Bears technique. One of the studies we read, you're just talking to the patient. You just screen them. Document it in your chart. We can also do health history reviews. You can add a few basic questions to your health history. Again, no doctor time. This can all be staff-driven. For the dentist out there, you can add a few simple health history questions. And I just put 4 in here. There's 100. You can come up with whatever you want. You just screen the patient. You just fulfilled the ADA's recommendation. Every patient should be screened for this. Phase 2, if they answer all those questions positively or negatively, however you want to say it, maybe you ought to give them a questionnaire. Dr. McBool gave several good options. In dentistry, we know we can't treat these patients. It's not an income stream for us. So we may try to do something a little simpler. This PSQ has been shown to be pretty good. It's a 20 or 23 question deal. Simple, easy to score and administer. Again, no doctor time. This PSQ has been validated with several studies that correlate pretty well with sleep studies. This little cheat sheet was designed for medical practitioners to let you guys see what these teeth should look like. Okay, so school, I think Case Western University up in Ohio developed this. So it's a little thing you could keep in your clinic if you want, or put out in your waiting room for the parents to look through it. But it just talks about all the different things teeth related, because we can see the teeth, right? You can look, the parents can see it, and so can we as doctors. But the facial changes, the writing's very small up at the top, but it just talks about that it's an index, it's a communication tool. It's all it is. So here's a narrow upper jaw, different patient, and we put our little measuring tools on there, and all the data shows, oh, that one's narrow. It shouldn't be so narrow. Well, you can just look and see. And if you don't want to measure, just look at the teeth. These teeth don't have room to come in. Those teeth stick out. Those are all the clues you need. There's a whole bunch more in that picture, but most of the clues are available right with the front 4 teeth. Just take a look at them. Count them up. Count the teeth. There should be symmetry. This is a different patient from the one I showed earlier, but this is very common. The permanent teeth, they just don't have room to come in. That's dysmorphism, probably related to something functionally that occurred in this patient's background. Count those teeth. That's where the missing tooth is right there, in case anybody missed that. We're looking for symmetry. You can do this just having the patient smile at you right before you stick the tongue depressor in. Look at the symmetry. If the symmetry's off, that mandible, the lower jaw, is being asked to function off to the side. That's going to affect the growth and development of their entire face if they live with this for their entire growing years. We like symmetry in orthodontics. The referral process, it's great having a pediatric sleep specialist here in our community. I think a lot of communities don't have that luxury. So thank you, Dr. McBool, for reaching out to some of us for this. And he's been a great resource for us with our patients that aren't responding to what we do. They aren't responding to the tonsillectomy and adenectomy. They need something else. It works in reverse. You know, we're getting referrals from Dr. Makbul as well. Ear, nose, and throat doctors. Any of those in the room, we'd love to work with you. Orthodontics and ENTs should be working together on a regular basis. We'd love to work with you. Orthodontists, you find an orthodontic specialist that's not just putting braces on everybody. You have to have expertise and training in this dentofacial orthopedics. So the orthodontist has to be comfortable seeing children. Not all of them are. Some of them have chosen to only see older kids or adults. So you got to have an orthodontist and a dentofacial orthopedist that like seeing children. For imaging, if you want to take some of these 3D images, very low dosage. I think an image costs a couple $100. Medical insurance covers it. Dental insurance covers it. It's great for baseline studies. The patient's upright. They're not recumbent, so it's just for screening. But you can get an airway analysis, and you can look at those airways that I was showing you, where you can actually pull that thing out and take a really good look at it, and that'll give you a lot of really good. That's the best case scenario of that patient's airway, because they're awake, they're upright, their muscles are functioning, and if they still have a small airway, it's pretty likely they're going to have some issues later. But there's no documentation of that. So thank you again for allowing me to participate in this, and I'll hang around after and answer any questions.